for both hospital and physician practices, physician compensation reviews, MSO network development, financial and revenue cycle assessment, and strategic planning. Immediately following today's presentation, we'll have a question and answer period, so please feel free to submit your questions in the area provided in the GoToWebinar dashboard, and we'll address each one individually by email. Or actually, we'll just go ahead and relay those to Jeff, and he'll answer them while on the call. The participant phone line will be muted for the duration of today's presentation. The materials will be emailed to you along with an audio playback shortly after the conclusion. I'll now hand it off to Jeff, who will begin the discussion, the revenue cycle supercharging processes to maximize collections. Jeff?
Thanks very much, Charlie. I appreciate it. Hello, everyone. Thanks for joining this afternoon. I appreciate your time. I know that everyone's busy and you'll have a lot on your plate. So thanks for joining in and listening and watching. I envision the presentation, frankly, taking somewhere around 45 to 50 minutes. And as Charlie said, we can do the Q&A at any time if you want to submit a question as we go along, and I will try to manage those as we go. Won't mention any names, so feel free to say whatever you would like. We'll protect the innocent here. So one of the things I like to do before I do a coffee with Coker is to get a sense of audience participation. There's such a wide array of folks nowadays in the practice management realm, many of whom have been purchased or their practice has been purchased by hospital systems, and so with different expectations. And usually what I like to do ahead of time is just get a sense of the number of providers and people's practices, whether you're in an employed model or you are in a private practice. So today's discussion will hit on some what I think are pretty key points in the revenue cycle. You have to understand that as we go through this discussion today, this audience, based on some of the information that I've seen, is pretty varied. And I'm hoping that everyone will be able to take a little bit of something away from today's discussion. And again, one of the things is if we don't speak to exactly something that you were looking to get out of this presentation, my hope is that you will get a Q&A session or offline anytime you'd like, and I'd be happy to just chat with you about some particulars that maybe didn't get touched on during the webinar. The goals today are fairly broad in that we're going to look a little bit at the revenue cycle process, RCM, revenue cycle management, whatever you wish to call it. Look at how some simple changes can have a large impact on your revenue cycle process. We'll look at some new approaches and things that are out there with regards to managing the revenue cycle. And then how changes in reimbursement might impact revenue cycle moving forward. And at the risk of being the bearer of bad news, maybe not so bad news, the things that are coming down the line are going to require much more aggressive management of the revenue cycle. So as I talk about the revenue cycle, a lot of folks envision this differently. So I will tell you, for the sake of today's discussion, really the revenue cycle for me starts at check-in and aggregation of patient data, and follows all the way through really to check out the submission of the bill, the charge slip, and the follow-up with the patient with regard to rescheduling their next visit, etc. So when I think of rev cycle, I'm not just talking about people submitting charges, collecting, and then chasing the money down after the fact. I'm talking about all those component pieces that play a role in the revenue cycle. So as we look at things today, we're going to look at whose responsibility the revenue cycle is, understanding the process, strategies for upfront collections, workflow, information, again, some new approaches, and then some challenges under the ACA. I guess with all due respect to the ACA in terms of how it impacts practices, both hospital employed and private, I think ACA sort of typifies challenges. I'm not sure there's a ton of great things that roll out of that in terms of revenue cycle management. So I thought this was an interesting quote, and this speaks really to team work within the offices. And again, I'm speaking, I think, generally enough in terms of an employed model versus a private practice, but no individual raindrop ever considers itself responsible for the flood. And if you look at that in terms of your office and the breakdown of staff members, no one person thinks that they're going to break the rev cycle or what they maybe necessarily what they do matters within the revenue cycle process. And everyone who touches or has a hand in the revenue cycle process really is that one individual raindrop, and they can make a difference in how efficiently the system operates. So in terms of, and again, I know we have varied management levels on the call today, but in terms of responsibility, there has to be accountability for everybody. And I hopefully this is not too vanilla and I'm not preaching to the choir, but honestly, everything that we do in practice management or running a small business for that matter, someone's got to own the processes that happen. And I would argue to you that revenue cycle is probably one of the biggest things that you need to manage. We're talking about dollars in the door. So we'll touch on that a little bit later. There needs to be, in my opinion, a person who manages the process and quantifies the process and keeps up with staff on performing the jobs that they need to perform. And that requires defining for staff what their roles are, delineating where possible some numerical quantifiable goals, and I would tell you that speaks to their evaluations too. So when you have evaluation time at the end of the year, whenever it may be, if you can measure your rev cycle folks based on certain numerical inputs and data, that goes a long way past the subjective piece of, oh, Susie's doing a great job and everything's going well. So everyone needs to work as a team. Everyone needs to understand that they're on the team too. So grab this from Spectron Company. This is really kind of the revenue cycle ecosystem, if you will. The system really requires constant feedback. It's not static. And so, you know, you have to understand the process from start to finish, and it needs to be managed, again, in my opinion, by one touchstone, so that when something goes awry, or even a process needs to be made better, that one person can analyze the data at the end point of the circle and then implement change to remedy that. So it's a constant kind of management of the process and tweaking it to improve it. It's never, ever going to be perfect, as with most things in life. But certainly it can be amended and changed on an ongoing basis. So hopefully, again, there is a person in your office who manages the revenue cycle aggressively. And that requires someone watching cash flow, looking at net collection percentages. Have those gone down or have they increased? An increase in accounts receivable, so a changing in the buckets. Maybe you used to have 60% in the 0 to 30, and now you have 80% in the 90 or greater than 120. That's a big issue. If your days in accounts receivable have increased, that's also another issue. If staff is getting bent out of shape, they're having payer issues, you need to find out what those payer issues are. When I used to work at the American College of Cardiology, one of the things that we did for the physicians was to have basically a database where we could track nationally issues that were going on with payers. Because in many instances you would see something pop up, and it wouldn't just pop up in Florida, it would pop up in Florida or the whole East Coast or Florida and California. So many times there are these little nuances that aren't only in your backyard. So keeping an eye on what happens with payers. If you're getting a big uptick in patient phone calls relative to their bills, outside of the normal, like, I didn't understand my bill, etc., but a trend in increasing patient phone calls and increased claims denial. Are you seeing an influx of denied claims? And if so, who's managing the reasons for those denials? Who's looking at those and trying to look for the common thread? So as I mentioned earlier, this all starts with the leadership, whether that's a billing manager or a practice administrator. Again, this really is predicated on the size of your office and the staff. And I will tell you, as an administrator from days gone by, one of the things that I think is a struggle in the trenches is that administrators and office managers are pulled in so many different directions. It's difficult to really focus on, but I would suggest to you that that's one of the most important pieces that needs to be managed on an ongoing basis in a very defined way. So you need to define who owns that process, whether it's a revenue cycle manager in a 100-doc practice or the office manager in a 3-doc practice. You should then diagram the steps taking into account the cradle-to-grave aspect, so sort of that life cycle aspect of the revenue cycle that I showed earlier in that graphic. I would suggest to you this is more important now with the Affordable Care Act, and we'll get into that a little bit later. You can diagram the internal and external functions, gather information, have sit-down sessions with employees. I will tell you my approach has always been that you surround yourself with great people and let them tell you what they need and work with them. So for me, this would be sitting down at a table with all the folks in the know about RevCycle and working through this with them so that they understand their roles in it. And so I, as an administrator, understand what I need to give to them to make them successful. Create incentives. I have a client who was not managing their front office collections at the time of service, so point of service or elective surgeries. They were not going after the patient's component at the beginning of an office visit. Well, we pointed this out to them, implemented some very simple changes, and incentivized staff to make sure, and obviously in a very straightforward and I hate to say salesman manner, but you're not going after the patient, beating them over the head to collect this money. You're working with the patient to collect the patient what the patient owes for, say, an elective surgery. They are now paying out 5-figure dollar amounts, not per person, but across the board in bonus money, incentive money, because they have now managed and are increasing their collection rates month over month. So create an incentive to get staff on board and get buy-in. Again, monitor performance. There's got to be a baseline, whatever that is, and we'll talk a little bit more about that later, but there's got to be a starting point. And then from there, you've got to say, here's where we need to go. Here's what we need to look at for metrics so that we can measure, monitor, and report back to the shareholders or your managing physician, whoever that may be, to let them know what's going on in RevCycle. And it may not always be a great report card, but as long as you can report back and say, hey, we're tracking this, here's an anomaly, here's what we're going to do to address that, and I'll report next month on how we fix that. Educate patients. Most patients have no earthly clue what is demanded of them via their contract they might have with their commercial payer or Medicare. You know, if you go in for a shoulder surgery, you're going to get an ASC bill or a hospital bill. You're going to get the surgeon's bill. You're going to get anesthesia. You may get a DME bill. These people are overwhelmed with the bills they get, and I would suggest to you most of them maybe don't understand all that. So it's up to you, at least in your end of that process, to let them know what will be due from them at the time of either the procedure or post-operatively. You need to understand the reasons for denials. You need to track that and monitor that. Someone, again, needs to be able to, whether it's the rev cycle manager or they've assigned that to somebody, and that live payer to see if things are trending, because then you can either remedy it with the payer or you can go back to the physician or PA or NP and let them know they're doing something wrong and not getting paid for it. I would suggest to you that you should understand your collection rates by carrier, and at the very least, understand where the bulk of your revenue comes from, whether it's Medicare, Blue Cross Blue Shield, or whomever. That way, even if you can't monitor every small payer that you have, and I know everyone has tons of little payers in and amongst the BCBSs and the Uniteds and the Medicares, if you can at least manage the bigger ones, you can focus on them, and it's sort of your classical 80-20 rule on that. And then understanding bad debt and write-offs, having policies and procedures in place to manage those. Interestingly enough, another client not too long ago, they would take whatever the insurance company sent to them and write off the difference. And so there, it's interesting, they reported to me that their days in accounts receivable were somewhere in the order of 25. My first response to that is always, that's a terrific number. It really is a really solid number. But then the kind of 25 years in healthcare kind of guy in me comes out and thinks, that's maybe too good to be true, so let's just vet it, validate it, and verify that everyone is collecting all the money that is due to the practice. So there needs to be a policy in place where 25 days is great, but let's just make sure we're not writing off money that we otherwise should have collected, which artificially makes the days in AR look good. Sorry about that. Okay, one of the things I like to use is, and this is just threw this out there, these numbers are fairly meaningless, but the structure itself and what it reports I think has a lot of value. So you might present something like this to, if you're in a big practice, you might have a revenue committee or a finance committee. If you're in a small practice, you might meet Dr. Jones on a Monday afternoon after patients to go over certain important data like patient visits, new versus established, surgery increases or decreases, things like that. But I would also put something together kind of similar to this. And many physicians I've worked with really like to see simple explanations for what's going on. So I would suggest you take something and you establish your baseline, whatever it may be, and then you put it out there to the physician and say, here are the things I'm going to manage and monitor, and here's why, so that the physician understands very clearly what it is that you're delivering monthly. And so in this example, what we've done in this is basically look at our year-to-date versus prior year-to-date. I'm working left to right at the top of the page. And then a change, and then what your benchmark is for that measurement. So you can see in the days outstanding, the year-to-date we're at 27 days. The prior year-to-date we're at 44. Our benchmark, we wanted to be under 28 days, so we're well above, well in line with where we need to be. That's just a great victory. Again, you need to understand, that's a huge pickup, cutting it almost in half. So the question becomes, is that a legitimate pickup, or did we have some folks writing off? So again, making sure you're managing that piece. The dollars outstanding, you can see, we reduced our days. Well, it almost stands to reason that our dollars outstanding should have gone down. Again, these numbers are meaningless. I just hope they align. But I will tell you that you look at year-to-date, we're at $150,000 outstanding. Prior year, we were at $185,000. Our goal is to be under $200,000. So we were looking good last year. We're looking better this year. Our charges, last year we were at $500,000. This year we're at $400,000. The thing with that is that what you do now with this data is you go back to the physicians and you look at patient visits and encounters where people on vacation. How do you explain the drop in charges? I will tell you that what that will translate into rev cycle, basically, kind of broadly, is that your revenues are going to probably drop within the next 30 days to 45 days once that $400,000 starts pushing through. The other thing you could do on this, too, as an aside, it just kind of popped in my head, was you could build this based on budget, too. So you could bounce your charges off your budgeted charges, things of that nature. You can see in here we broke down all the kind of prototypical or the typical aging buckets, and we're doing pretty well in on the aggregate. We've got 85% of our AR in the first 60 days, which is pretty robust. The net collection rate, you can see that we improved that dramatically. I would suggest to you, your net collection rate, unless something is really insane in your practice, should be almost 100%, because the net dollars are what you expect to get, right? So if I have a fee schedule of 100 and my adjustment with Medicare is 20 and they will pay me 80 for a service, I should collect 80 bucks or 100% of what's due me. I know that doesn't always happen, but net collection rate should be somewhere between 95 and 100%. The cost to collect, you need to define all the costs that are involved in your rev cycle process and put a percent on the overall revenues that are collected. You can see in this instance, the prior year to date, we were at about 6.9%. This year we're at 4.4%, and we're pretty happy about that. Let's see, the balance check-in, that was simply just a matter of how much our front desk is collecting at the time patients check in. So more than anything, obviously aside from the numbers, what we're trying to get to here is a snapshot of what's going on in rev cycle. That can be shared with physicians, and if you want to, share it with staff. I would suggest sharing something with staff so they have feedback and they know what's going on. And I throw some colors in because it draws the eyes, shows you where there are issues, stands out a little bit. So strategies for upfront collections. Strategies, analysis of your AR on a monthly basis. You need to understand any fluctuations that transpire with AR. So if you're having an issue of, again, we put in there on the last slide, collections at the front. If collections at the front are an issue, you need to sit down with your front desk folks, find out why, find out if maybe as management we're not delivering a vignette to them that they can share with patients, and so they can't. That's a difficult discussion to have at the front desk. So if we haven't coached them into how to get a hand on that, that's on us, and we need to work with them on that. Organizing delinquent accounts. Suggest to you that you need to define and delineate those biggest pieces that are out there. Again, it's sort of an 80-20 rule. If you can get 100%, get 100%. But if your delinquent accounts, you have 80% out in patient pay that's been out there for greater than 120 days, you need to figure out how you can define a plan on how to go out and get that money. If that money's sitting with Blue Cross Blue Shield, that's should be theoretically easier. Because if your claims have gone out correctly, you can go out and get that money from Blue Cross. They're obviously obligated to pay you. Patients are obligated too, but remember that, and as you all know, physicians are usually the last bill to get paid out of the stack at a patient's house. So define role of a customer service representative. If you can do that, small offices will be hard-pressed, I think, to dedicate a person full-time to being a customer service rep. But maybe you have a person who doubles as a financial counselor who can work with patients in a place away from the front desk to talk to them about, what will be owed at the time of surgery or post-operatively or in their whole care plan. Create a welcome package. You want to obviously let patients know. I would assume that most of you have, for instance, a new patient package. I would also assume that in that package is a listing of what the financial expectations and what the financial and billing policy is for the practice. Conduct a coding and billing audit. These are always a good thing. Even if you don't think you're in bad shape, there's always something that can be found. And I would suggest to you that it can't hurt to keep physicians and PAs and NPs and other providers on their toes so that they look to see or look to get educated on new changes. They look to see that they're not all billing level 2s for a level 5 visit. And frankly, I would quantify that for them. If they're legitimately doing 4s and they're billing 2s, show them what that means financially to the practice, but also to them. Because if you're on an eat what you treat or RVU driven model, and your physicians are billing all 2s, they're obviously costing themselves and the practice revenue. Should again run exception reports to see what's kicking out and why. You should do that by payer to understand where the anomalies are. You may find, if you break this down by payer, that a fair amount of your exceptions are with a payer, and they may be with one denial code. Managed care collection versus self-pay. I would actually say just understanding managed care collections piece, making sure that the fee schedule for your top 80% of your revenue payers that we talked about earlier, I would make sure that those fee schedules are loaded in your practice management system, and that when those revenues come in, they get bounced off in some way against that allowable to make sure that the payers are paying you what they're supposed to for what the agreed upon contractual rates are. Report, educate, and involve staff and providers. This gets back to the life cycle. So you implement your plan involving your staff in the design and development. You provide them feedback, education, and you remediate based on what actually happens when the plan's implemented. And I think this constant work with the staff is essential to inform them and keep them involved. And honestly, if they have a stake in it, people are much happier when they feel like they're really contributing. Conquer coding, that is more of a, again, of accurate coding, billing, and auditing. Strategies need to start at check-in. this is where the rubber meets the road. It's pre-visit, verify eligibility, insurance information, maybe have a managed care matrix at the front desk. I know of practices that have deployed kiosks that will pre-verify and check information. And also there are other e-tools out there to ensure accuracy. I guess I'm not surprised. I feel like I should be surprised that there are people out there still who fail to ask for the insurance card at every single visit. And instead what happens is at the front desk in some instances is, do you still have the same insurance, Mrs. X? Oh yeah, sure. And then we come to find out that right off the bat, the process is broken, and because that claim is going to go out dirty, it's going to get rejected, and then you're going to have to chase Mrs. Smith around or her actual new insurance company. People should get insurance cards at the front desk. They should check them every time that a patient arrives. Management needs to analyze and update the fee schedule. A lot of people set their fee schedules at some percent above is what it is. There's a logic to that, I suppose. But one of the things you need to be very careful of is the contracts and the terms of those contracts. And I'm not talking about looking at, again, that little group of payers who you have 5 patients. I'm talking more about BCBS, United, Cigna, or the other payers to understand that, is my fee schedule tied to Medicare's fee schedule? And of course, that means that anytime Medicare cuts, you're going to get a cut in your BCBS or United fee schedules as well. And if these are evergreen contracts where they just roll, you're going to be a little surprised. Well, you're not going to be, because y'all will run your rev cycle really tightly. But some people who don't do that are going to be surprised to find out that their reimbursements from Blue Cross Blue Shield have dropped, even though they're seeing the same or more patients and they can't figure out why. So, educate staff roles, detail that you would provide to physicians. Give them percentages or give them a broad brush stroke to show where they are so that they can see improvement or see where there's some deficiencies. Staff love to be challenged. Educate providers and manage their expectations. Sit down with the doctors. Either if you have educated physicians with regard to the rev cycle, I would get input from them. But if I were you, I would also do a lot of legwork on my own to find out what the benchmarks are for my specialty, for my location, for my area, and build a deliverable for the physicians that's very simple, clear cut, but gives them all that they need, a one-page snapshot. As I mentioned earlier, develop a component for staff evaluation that includes objective measurements. I love doing this because what I hate to do at the end of the year is sit down with Susie Q to do her annual evaluation, and she's been doing great for the last 2 weeks, and that ends up on her eval. Great year this year. If you can quantify pieces and hold people accountable for those pieces, that's just much easier when you get into the staff evaluation process at the end of the year. Develop relationships with payers, identify key contacts. It's always great to have a go-to person at the payer level. And you need to find, it's obviously using a little bit of sugar to get what you need, but develop that relationship. It will earn you tremendous rewards as you move forward. I talked about payer tactics a little earlier, and it's worthwhile to understand what they're doing. There may be something they're just denying because, I hate to say, maybe they just deny it up front. And if that's the case, why are they doing that? Let's figure that out, especially if you're in a specialty where you perform, I'd call them kind of maybe not off-label, but procedures that don't happen frequently. You've got a subspecialty, maybe you're doing some sort of weird retina thing or something like that, and it requires 25 pages of documentation every time you do that procedure, then maybe you need to work on your rapport and talk with the payers about, hey, can't we just do this? We'll give you this every time. Let's just make sure these get through the system. Because invariably, those are the procedures also that wrap up a lot of high dollars. When the dollars are due to the practice, ensure that 100% office collection happens up front, We talked about that earlier, build it into evaluations. Create tools and vignettes for the staff to manage over-the-counter collections. Again, I have to tell you frankly, that's not a job I would want to do. That is a hard job. Front desk is hard. And if we can work with them on simple vignettes such as, oh, Mrs. Jones, you don't have your checkbook? we take MasterCard or Visa, things like that, where it's softer sell, less abrasive, no hard edges, and if the patient needs to be counseled in another area due to financial issues, then perhaps you can meet with them in another room to discuss payment options, payment plans, etc. Make sure that staff reconciles patient payments with encounter forms. There needs to be a check and balance with that process so that all encounter forms are reconciled at the end of the day and that there has been a payment received unless otherwise stipulated for those encounter forms. Payment plans in place. I like to get as much as I can up front, but the physician office visit can be expensive, and it's always helpful to have a payment plan in place that's reasonable, that ensures that patients keep up with their with what they owe the practice. Liken it to this. I know it's healthcare, and it's a little prickly to ask patients for money with healthcare, but you don't go to the grocery store, load up on groceries, go to checkout and say, well, I'm going to pay for 50% of these, but I'll be back next week to pay for the remaining 50%. So while it's healthcare and we need to be sensitive to that, we also need to be sensitive to the fact that this is a business and your physicians don't provide services for free. In fact, I would tell you they probably do donate a lot of their time, but the goal of keeping the business moving forward is obviously to collect some revenue. Non-covered services, Medicare ABN notices, there's got to be, there have to be methodologies in place where if the service is going to be non-covered, staff needs to get that out in front of the patient so that the patient sign, they understand they have financial responsibility for the uncovered service. Patient balances, overdue accounts, collection agency, in-house collection, these are all components to the patient balance aspect, and I would say that all of these require some sort of thoughtful process put in place. It doesn't have to be war and peace with regard to process, but a couple pages of here's what we do to go after overdue accounts. Here's our collection agency. We go to them for this. We punt it to them at a certain time. If they don't get it resolved, they come back to us and all that good stuff. Collection letters, divorcing patients for non-payment, which is always a very sensitive issue with physicians. When you're developing the process, you've probably taken an EOB sample and run it through your process. So did we collect, so again, it's just a draft sample run through, a test of your scenario, a test of the process you've built for your rev cycle. Have we collected the copay? Is the accurate form filled out? Did we get full payment, denial? Follow it through the process to make sure before you deploy the process that the draft process, if you will, that is tenable, and then amend that before you deploy it fully. This speaks to the cycle, the cyclical nature of the process. After you've implemented and changes have been identified, involve staff in similar exercise, monitor all the changes that are in place, and again, you've got to have some sort of quantifiable measure out there so you can monitor what has happened. If things haven't gone well, reassess, revise, and again, always keep the physicians in the loop. Most physicians that I know and I have worked with like to know more than less and don't like surprises. Physicians have they have an impact on everything in the practice, whether you're employed or you have a private practice. If you have a private practice, you're going to have, I think, a differing degree of physician involvement, whether physicians are partners or they're employed, but it's essential to let them know the role they play in the rev cycle process. And that means from accurate coding to follow-up, making sure that physicians are educated in their aspect of the process. I threw this back out here again just as a little bit of a reminder. It sort of backs into some of those things that we just kind of talked about earlier, some of the component pieces that we would want to measure in a very simple format. The customer service rep, forgive me, I put that back in. I'm sorry about that. Depending on your practice size, the number of FTE clinicians, that may or may not be doable, but it is always good to have someone who is a go-to and to have a backup for that go-to on financial policy and procedure and who can assist patients as a one point of contact to get issues resolved. I'd say outsource services when you can, but the conundrum with that obviously is you lose a sense of control, and I would suggest many groups that outsource tend to look away after they've outsourced. I had a client who outsourced their all of their collections, and money flowed in, which was reasonable, but what happened is the older money never got chased, and that stuff aged and sat and grew. And so as we went to look, we looked at the aging and noticed that things were not quite insane, but really close to insane. So when you outsource, there's a tendency to just trust and walk away. So it's one thing that needs to be managed with regard to that. Automate the process and workflow as much as possible. It would behoove you to look at all the tools that are out there now, from kiosks to the insurance eligibility online things, and anything that you can use electronically. Obviously, there's got to be a look at the return on investment. You don't want to spend money willy-nilly to deploy these things. But you can also make an argument that if I deploy kiosk number 1, how much time or can I cut an FTE or reassign an FTE front desk person to somewhere else in the practice? So it's looking at the expense versus the savings and maybe even revenue generation, doing that math. We talked about this earlier. Don't assume the patient understands their insurance coverage. Most of them don't. I will tell you, I hate to say this, I don't. I go and give my card and pay my copay. And I presume that everything I get from people is what I owe them, although I will look if it's a huge amount. Claim scrubbers, clearinghouses offer an array of payment options to patients, especially if you are in a high dollar, say, orthopedic surgery, or if you're doing a high dollar elective, maybe in vision correction, and vet all of these pieces against the return on investment that involves the cost of any hardware, but again, also savings, not revenue generation necessarily, but really truly the savings of any staff that can be removed from the position or moved to a better, more efficient spot within the clinic. Okay, workflow. I don't know that you want to do this diagram necessarily or anything like it, but it might behoove you to sit down at your desk with a piece of paper and just out. That really indicates the process and the procedures. This one's even worse, and I would suggest to you not to do this. But it does give you an idea as you work left and right across the top, those pieces that happen when they should happen, and as you work down north to south, who owns that piece. And so it's a simple kind of yes, no. If this happens, yes, then I do this. If that happens, no, then, or if that doesn't happen, then I do the other thing. And you can talk through this with staff, because if you're like me, visual representations work much better than just people sitting around the table jawing about things. And if you can talk about these things and delineate some sort of flow and process and show folks, they're going to come up with a bunch of ideas, I think, that can improve the process and really solidify from front to end what happens. And this is just a takeoff of the prior. So the front office functions, and then the business office functions. So this is actually a client that we had. Couldn't figure out where the money was going. And what we did is we drilled down. They couldn't understand why collections were low. And we drilled down in all these component places just at the front desk and came up with these issues and quantified those to figure out that there was about $501,000 in avoidable front office errors. Now, granted, nothing, as I said earlier, nothing's going to be 100% ever. It just isn't. But, of course, it doesn't hurt to strive for perfect. And obviously, this error rate is far from perfect. So if you go through an exercise like this, what is the target going to be? Again, this is a quantifiable, measurable thing. And you can say to staff, you know, our goal is to be at 5% error rate at the front desk, and then measure that on an ongoing basis. Here are some provider issues, and this is why you've got to involve your providers in the process. And I know they have a hard job. Coding's difficult, hard to stay up with all the changes. I get all that stuff. I do. Hopefully you've got someone on staff in-house who's a CPC, maybe even a specialization in with their CPC in whatever specialty you're in, who can help address some of these things internally as you move forward. Same kind of exercise. What you found out with this client is 19% of procedures, 5,669 procedures, over $500,000 of avoidable mistakes. And you're not going to avoid all that 500,000, but if you can get that down to 150, I'd say that's a pretty good win. Path of the claim, probably just zip on through this, but this is something that I alluded to earlier, which is get that demographic information up front. Include your staff in this piece of the process. Is there a possibility for LMRP? Get an ABN. If not, then you render the service. The account form is complete. So this very simple yes, no, if then type of exercise that will help you visually define, as I define the revenue cycle process, which is from front desk to checkout. So talk a little bit about some of the collection rates, and I will tell you that I'm not a fan of the gross collection rate. Here's why. Gross collections, look at it this way. If I'm a family practice physician and I decide I'm going to charge $1 billion for a level 3 office visit, and I have a Medicare patient, they're going to pay me $50 or $35 for that office visit. So why would I even be concerned with a gross charge of $1 billion and a gross collection driven off of that number? It doesn't make any sense. For me, when I look at gross charges and gross collections, I would only really take them as a valuable measure if I don't change my fee schedule, because they can be indicative with other numbers of either growth in the practice or a declination in the practice. So in other words, if my fee schedule is $1 million for everything all the time, and granted I might get $500,000, but my charges are always $1 million. If my charges go up to $1.8 million next year, then I know that business has increased, all things being equal. And you can measure that, obviously, against your encounters, against your patient volumes, etc. But for me, don't love gross collections, and here's why. I charged $100,000, I collected, or $1 million, I collected $100,000. My gross collection rate is 10%. Okay, well that's nice to know. I do like net collection, and y'all should at least enjoy understanding net collection. But so net collection obviously is going to be your total collections divided by your net charges. Net charges are obviously what your fee schedule is less any adjustments. So in this case, I'm charging $1 million. My contractual adjustments are $450. My adjusted charges are $550, and I collected of that $550, $475. So I'm at 86% roughly. As we talked about earlier, I don't love 86%, but it's a number for me. And so it's a baseline in this case where I can go sit with staff and say, we're at 86%. We need to be at 90% next month, 92 the month after, 95 after that. Again, it gives you data that has some value and enables you to figure out why are we not getting 100% of the $550,000 that we should be getting. Days in AR, obviously everyone hears this number. There are a couple different avenues you can do this. You can do this math by 30.64 as your multiplier, or you can use 182.5 or something like that. People have different ways to get to that number, and they will all give you pretty much a consistent output. So you can see in this example, we use that multiplier of 30 and a half or whatever. So our total AR was 350. Our average charges was 650. So we're running 60.5 days in AR, which is obviously saying that it's taken us roughly 60.5 days to collect the money that is due us. Now, as I said to you earlier, I would look at that, and my first reaction would be, that's, holy cow, that's insanely good. And my second reaction would be, I've got to go see what the write-off policy looks like and see how much money's been written off over the course of time. Because I just want to vet, validate, and verify that that 16.5 is a real number, and then I want to see the leader of that revenue cycle team out there presenting all across the country telling everybody how they got the 16.5 days, because that's really good. Adjustment percentage, total adjustments over total fee for service charges. Not a big fan of that as a measurement necessarily. New approaches and other options. Some of these are simply other options to farm your rev cycle out. The process, if you're looking to do this, obviously is, as I mentioned, what is the cost, what is the revenue, or am I saving? Do those offset each other? And do I trust parsing this out, this very important piece of the overall business? I mean, you are the dollars and cents earners, or the people who bring that revenue in. Do I trust someone else to manage this process on my behalf? So you have traditional outsourcing and third-party billing, a lot of times charge-based. I'd be careful of a charge-based. If your fee schedule is high, you're obviously going to get dinged on those charges, which are not your net dollars. I also look very carefully at a percent of net collections, because there are some TPAs out there who will collect the money. If claims go out cleanly, they get their piece no matter what. But if there's rework to be done, maybe some of those sit on the back burner because there's not a lot of revenue generated from those, which means there's not a lot of money that flows through to the TPA. You can use an ASP model, which is fairly traditional outsourcing. Again, the charge based on percentage. Any of these that you elect to do, I would most certainly try to negotiate out on those. I would also make sure that you, if you're interested in going this route, make sure to vet out a list of clients, and hopefully not just the clients who love them. Hopefully they will just give you a raw list of clients that you can call to talk through the process and their either content or discontent with what's going on or with how things work. These can cost 5 to 15% depending on the service and what you elect to do. Many of these should be on the order of 5 to 7%. Considerations for other options. Mention check-in kiosks. These are automated systems that you can use to have patients. I know one practice actually here in the greater Atlanta area, all patients hit the check-in kiosk first. They actually put a representative out on the floor to do nothing but assist patients initially with getting a feel for the kiosks. And their days in AR, this is not a monstrous practice, it's a single specialty practice. They have, I want to say, 25 providers in the greater Atlanta area. Their days in AR, I think, are about 23. And I know the CEO fairly well, and I know that he's got policies in place to handle those write-offs. So that 23-day number is a true number. Interestingly enough, even in the era of declining reimbursements, he has told me that their revenue has gone up year over year for the last 3 years. Now, that's not to say there aren't other moving parts. We all know that what we do has many variables, and there are a lot of moving parts in what we do. But it is to say that the collection of money that's due the practice, especially on the front end, versus deploying the expensive back end and chasing patients around, has a lot of value to it. Again, I talked about performance and references and past successes for any vendors you use. Vet the cost in-house versus farming it out. See if they work with your existing system or proprietary system scope of services. What I would ask that you do, and don't laugh at this, I will say in your copious free time, and actually it's kind of sideways, but when you work on the process, if you don't have one in place, I would seriously vet any possible component piece that's available in each step in your process. In other words, the kiosks at the front desk, verification, maybe a service to pre-verify if that's financially viable. All manner of tools that are out there to electronically handle this that may tie into your PM system and may work with your EMR system if there aren't a lot of interfaces that need to be written, that you can use to, because let's face it, I'll say in many instances, the electronic modalities are going to be closer to error-free than staff. That's not to say they're not without their flaws, of course, but computers actually seldom make errors. I think it's 1 out of every 5 billion calculations. So in any event, the changes in reimbursement, and we're running close on time here, about 10 more minutes. Changes in reimbursement, I mentioned this a little early and I'm going to elaborate it on now. The days of passively managing revenue cycle have passed us by. So oftentimes when money was good, the money came in, everyone was happy with it, physicians made a lot of money or a fair chunk of change or even decent money and they were content, people didn't pay a lot of attention to how the revenue cycle worked. And I think that with the Affordable Care Act and bundled payments, ACOs, value versus volume, the need to manage the dollars and the process to collect those dollars that come through the door is more acute now than ever. Medicare changes in reimbursement are coming. Depending on your specialty, that's going to have a huge impact on revenue. If you're in cardiology, you know that a fair chunk of your patient blend is going to be Medicare. So more than ever, it's essential to watch the revenue flow and how that is working throughout the practice. The value versus volume, the pay for quality, bundled payments for a service such as congestive heart failure, all the lumping of the treatment of CHF into one payment scheme, that's all going to impact what you all do in terms of collection of cash. There's more reporting that's going to go on. There's more collection of data that's going to need to take place. And the charging and reimbursement and compliance data is all going to be collected. So if nothing else, if you don't address anything in your rev cycle process, you are going to have some sort of robust IT component in your practice to make sure that you can manage your data. So I would tell you that, and I know there are a lot of practices that still don't manage their data. You are the keepers of a tremendous amount of information, and it behooves you, and I think it's actually essential for you to understand the data that flows through the practice, whether it's patient visits or whether it's clinical care and the number of new patients or the number of valves your physician put in. All of those component pieces are essential for you to know, own, and manage. Manual and e-systems should help you better manage the value proposition and the revenue cycle, as I mentioned a little bit earlier. And it is essential to measure and manage your data to ensure reporting and accurate payments. RAC audits are going to require more documentation. Advanced IT systems, as I mentioned, can help you with all this stuff. The data pieces are out there, and I'm pretty sure that no one on this call is using an abacus. So even if you have an old IT system, it's still got some sort of value with regard to your data in your shop. And you need to analyze those pieces that are important to the business that will help you move forward in the new affordable care era. Revenue cycle systems, manual and electronic, have to aggregate and analyze a lot of information from insurance eligibility authorizations to payers to coding outcomes. I mean, clinical outcomes are going to be huge, and they're not there yet, but I would tell you that it's time to really start thinking about that. We have not made the leap over the chasm from fee-for-service to pure pay-for-performance, but at some point there's going to be that gentle walking or that big leap from one side to the other, and people need to start thinking about that and getting ready for that eventuality. Patient-centered medical homes, pay-for-performance, all those care plan designs are coming with higher deductibles. So what that's going to mean for you, obviously, is patients are going to walk through the door. They just bought their new insurance, which may or may not cost them more. And a lot of these plans have higher patient responsibility. How are you going to manage that now? Where once I had a Blue Cross Blue Shield plan, I paid my $10 copay, and they covered most of everything else. I now have to pay a $50 copay, and I've got some sort of weird 80-20 situation where I've got to pay the other piece of that. Your staff needs to understand the patient responsibility, and you have to be ready to gently ask patients for what they owe you. Yeah, the other bullet I wanted to speak to relative to that, with the expansion of Medicaid in several states, you're going to have patients who may otherwise have avoided care, and if they have, they might be a little sicker. But in any event, they're going to be, the expanded Medicare or Medicaid rolls are going to have a fair chunk of patients where the payer, Medicaid, doesn't reimburse very highly. So that being the case, it's going to be incumbent again upon staff to be aware of that, to understand your patient mix, and to be ready to collect the money that's due. So when we talked about AR just a touch, I just want to throw this out just to show your likelihood of recovery of AR. So within the first 30 days, you're looking to get about 93, 94%, 90 days, 6 months, and then a year. And I would suggest to you that year number is probably actually worse. So just to sort of tie up some loose ends, this is a life cycle. It is certainly a process that needs to be tended to, and the only way to tend to it is to establish what it is, assign a leader or owner to the thing, and develop quantifiable measurement aspects so that reporting can happen, measurement management can happen, and the system can get tweaked and fixed on an ongoing basis. So review processes, document processes, get input from staff. The people in the trenches are a wealth of knowledge, boots on the ground of what's going on a day-to-day basis, and then provide them with education. Revisit that life cycle on an ongoing basis. You have to understand it to optimally manage it. Data capture up front is critical. Again, the fallback of, hey, Mrs. Smith, has your insurance changed? No? Okay, good. You just can't do that anymore. Provider coding, it's the PROC code, it's the DX, the modifiers, they're all critical to clean claims going out. Claims that are backed up by the documentation and the history and physical that will support the billing level. Review all of your processes and begin to build a list of those vendors. It doesn't have to be in one sitting. You could just start this list on an ongoing basis, put a defined timeline, because I know everyone gets busy and they'll forget it. But within 30 days, just start noodling at each of your processes to see what is out there that may make your life and your staff's life easier and maybe more efficient. Explore all these e-processes to determine if they fit, and run the ROIs, not purely on what this is going to cost me, but what it will both save me and generate in terms of revenue. As I mentioned earlier, rev cycle can't be a passive exercise anymore. It has to be managed aggressively on an ongoing basis. Had just this little vignette. Wealthy and well-known businessman's wife breaks her hip. Businessman goes to the best bone surgeon in town for the operation. Operation consisted of lining up the broken hip and putting in a screw. The operation went great. Doctor sent the businessman a fee for his services $5,000. The businessman flipped out, was outraged, and asked for an itemized breakdown of the cost. Doctor said two things: screw $1, knowing how to put it in, where to put it, $49.99. Value your knowledge and embrace it, and understand that and money, and we should collect that money. And that's it for me. Questions or comments? I did get one question. I'll throw this out there really quickly. With regard to days in AR, there are benchmarks out there, of course, that you can get to evaluate your group and their AR relative to peer groups. You can do, I will punt this a little bit, and I will kind of equivocate in saying that there's no magic bullet for this. Your days in AR, you can benchmark it initially, but it's also predicated on your patient mix. You may have a higher days in AR value or more in the aging buckets if you have a high low pay program, Medicaid, or a high self-pay, or if you're in a high dollar surgical or other specialty where the charges and expected payments are fairly robust. That is orthopedic surgery. If your docs are orthopedic surgeons and specialize in hands and whatever else, and they're doing hip replacements, those high-dollar procedures may inflate things, work through the process, or you're doing specialty procedures like some sort of cutting-edge orthopedic surgery or ophthalmologic surgery on patients. Those things will need to be many times screened by a physician on staff and a payer. So the short answer is there are benchmarks out there. I'm happy to talk to anybody about those and try to work with them and give you my 2 cents on what those might look like for your specialty and where you're located and how to manage and monitor those. But there is no silver bullet answer. I would suggest to you that what I like to see minimally is roughly 50% AR in the 0 to 30. That's kind of one of my goals. So with that said, and no more outstanding questions, if anyone would like to get a hold of me, my contact number and my email address are both at the bottom of the final slide. I encourage you to take those down. Just call me and let's chat if you'd like to and you need to. And that is it for me. I appreciate your time. I know you all have a lot to do, and I wish you good luck in solidifying and moving forward with your revenue cycle processes.
All right, thanks, Jeff, and thanks to everybody for joining us. Again, the slides, the presentation, and the audio link will be emailed to you. Please check out our website in the meantime at www.cokergroup.com for details for the next Coffee with